Hello and welcome to your Chapter 29 lecture continued, where we are going to talk about alterations of our leukocytes. And our immune system really relies on our leukocytes or white blood cells to fight infections and keep us healthy, of course. But what is really going to happen when their functions become altered? When we have a deficiency in the number and the quality of our leukocytes, that's going to be known as leukopenia. It weakens our body's defenses and it allows it to make infections a little bit more likely. Now, if we have, on the other hand, an excessive increase in our leukocytes, that is called leukocytosis, and often that signals an infection, inflammation, or even leukemia. We have a lot of hematologic disorders that affect blood and are actually malignancies, meaning they involve abnormal and uncontrolled cell growth. But it's not just blood cancers that are going to impact the leukocytes. We have other types of cancer that can metastasize or spread to other areas of the body, such as to the bone marrow, which of course then is going to disrupt our normal white blood cell production and function. So we can take these alterations of the white blood cells and put them into two main categories, quantitative and qualitative disorders. When we describe a quantitative disorder, it involves an increase or a decrease in the leukocyte numbers and low production in the bone marrow, or rapid destruction in circulation can lead to immune deficiencies. While when we have an excessive increase, that will often be seen in infections or leukemia and can show us some type of disease taking place. Qualitative disorders are affecting how our leukocytes function. That's our key word there. So our phagocytes, such as our granulocytes, monocytes, and our macrophages, may lose their ability to engulf and destroy pathogens. Meanwhile, our lymphocytes may become unable to recognize or respond to the antigens, weakening our immune defense. And so with either of these categories, it can really leave our body vulnerable to infections and disease. Now, when we have leukocytosis, we've talked about this in the previous slides, but it occurs when our white blood cell counts are higher than normal. This could be a normal response to stress, infection, or inflammation, but it can also be pathological, which we see in conditions like leukemia. On the other hand, leukopenia is when we have that low white blood cell count and is always abnormal and increases the risk of infection. From a nursing perspective, monitoring the white blood cell levels is going to be important. For leukocytosis, we can assess for infection, inflammation, or an underlying disease, whereas for leukopenia, we have to take extra precautions, right? Making sure we are implementing infection control measures, ensuring we have proper hygiene, close monitoring for early signs of infection like fever or fatigue. And so understanding these alterations can help give proactive care for your patients. And here is a question for you. An individual has leukocytosis. What would the nurse expect to find while taking the individual's history? So I'll let you read through these options. And if you answered number 1 as the correct answer, you are correct. When we have an increase in leukocytes, it's a normal protective response to physiological stressors that can include exercise, pregnancy, infection, emotional upheaval, temperature change, and surgery or trauma. Whereas a history of autoimmune disease could be more of an indication of leukopenia. That could be also caused by radiation, anaphylactic shock, or other immune deficiencies. And a history of radiation treatments that again can produce leukopenia, as we mentioned. Same thing with the immune deficiency disorder. Moving on to our granulocytes and monocytes, are really focusing on these. And if you remember, our granulocytes would include our basophils, eosinophils, and neutrophils, whereas our monocytes are agranulocytes. And we know that whenever our body faces an infection or inflammation, it's going to respond by increasing our neutrophils. which we know are kind of those first defenders of our immune system whenever the white blood cells are called upon. And so this is called granulocytosis or neutrophilia. Remember that philia means loving, neutrophil loving, and it's often the first sign of an immune response, like we said. But what happens when the body can't keep up with the demand? Then we're going to start releasing immature neutrophils into circulation, which is a process known as shift to the left. This can be seen in severe infections or inflammatory conditions, and in extreme cases, an excessive and rapid increase in our white blood cells can mimic leukemia, and that is called a leukemoid reaction. So as a nurse, you want to be able to recognize these changes, and if we see this shift to left taking place, then we know that our body is fighting a significant infection, and we need to monitor for fever, sepsis, or worsening inflammation. Now, when we have neutropenia, this is more of a dangerous reduction in their circulating neutrophils. The white blood cells that are specifically neutrophils will drop too low, and our body becomes highly susceptible to infections. The causes of this does vary, but it could be from prolonged severe infections, decreased bone marrow production, reduced survival, or abnormal distribution of our neutrophils, and we can classify them as either being a primary neutropenia or a secondary neutropenia. So that primary neutropenia could be congenital, which is seen in conditions like cyclic neutropenia and immunodeficiency syndromes, whereas acquired neutropenia is linked to diseases like aplastic anemia that we've talked about, leukemia, lymphoma, and myelodysplastic syndromes. Our secondary neutropenia often stems from immune disorders or certain medications such as chemotherapy or immunosuppressants. So people that are suffering from any of these neutropenias need to have strict hand hygiene and possibly protective isolation and close monitoring for fever and signs of infection. When we have granulocytopenia, which is also known as agranulocytosis, so think about our granulocytes, those basophils, eosinophils, neutrophils, they're at low amounts, which means that we are probably going to have higher amounts in comparison of our monocytes and lymphocytes. And so being in this predicament, we're going to have the body be highly vulnerable to infection. And it can result from disruptions in bone marrow production, which we know is called hematopoiesis, immune system dysfunction, chemotherapy, or ionizing radiation exposure. And without enough of our granulocytes to fight infection, patients can develop persistent life-threatening infections, especially within their respiratory system. And if it is untreated, then septicemia can be caused by agranulocytosis, and that could be fatal in just about 3 to 6 days. So you want to closely monitor this patient to see if they're having any type of respiratory distress and, of course, any signs of infection. And in certain cases, they may need to give the patient granulocyte colony stimulating factors. If you remember, this is going to be a factor that is going to stimulate white blood cell production so that we can kind of boost up the immune system. Now, our eosinophils, if you remember, play a key role in allergic reactions and immune defense, but when their levels fluctuate, it can indicate some health issues. So if we have eosinophilia, then we are going to have an increase in our eosinophils, and that's typically triggered by an allergic reaction or parasitic infections. During a hypersensitivity reaction, our mast cells can release eosinophilic chemotactic factor, which draws the eosinophils to the site of inflammation. And we see this a lot in people that have this type of specific asthma, hay fever, or other parasitic diseases. Now, if we go on the opposite end of things and we have eosinophilia, that is going to be a decrease in our eosinophils. And that really takes place when our cells migrate to inflammatory sites. And it's also been linked to surgery, shock, trauma, burns, and even mental distress. So people that have eosinophilia may need more allergy management or anti-parasitic treatment, while those that have eosinopenia may require monitoring for stress-related complications. And now we have our basophils, and if you remember, they are the least common type of our white blood cell, but they do play a big role in our immune responses, and especially when it comes to inflammation and allergic reactions. So if we have basophilia, that's going to occur when we have an increase in basophils, and is typically due to inflammation or a hypersensitivity reaction. These cells have histamine and is going to be released during the allergic response and contribute to symptoms such as itching, swelling, that bronchoconstriction, which makes it hard to breathe. And we see that a lot in, of course, asthma and anaphylaxis. Now, on the other side of things with basopenia, that's when we have a decrease in our basophils, and that is typically linked to acute infections, hyperthyroidism, or prolonged steroid use. And while it's not really discussed commonly, it can really indicate an ongoing stress response or immune suppression. So if we have basophilia, then we can give antihistamines or anti-inflammatory treatments. Whereas with basopenia, we want to look for those signs of immune suppression or any type of underlying endocrine disorder. And now for our monocytes. They're going to be key players within our immune system as well, and they act as our second responders when our monocytes move into the tissues and turn into macrophages in order to fight infections by doing things like phagocytosis. And so if we have monocytosis, that means we have an increase of the monocytes, and it typically takes place alongside neutropenia. Remember, that's when we have a decrease in the number of neutrophils. And it tends to happen in the later stages of a bacterial infection. So it's also linked to chronic infections and even myocardial damage, where our monocyte levels correlate with the extent of that myocardial tissue injury. Again, injury to our heart tissue, that is. And if we are on the other spectrum of things, our monocytopenia means that we have a decreased amount of our monocytes. And unfortunately, this is less understood, but we have seen it in patients receiving prednisone treatment or those with hairy cell leukemia, which is a rare blood cancer. The last cell type we're going to talk about are our lymphocytes. And these, of course, also work within our immune defense, but their levels tend to rise and fall depending on what we really have going on within our body. So if we have lymphocytosis, that means we have an increase in our circulating lymphocytes. And to remind you, these are our B and T cells. And we usually see this happen when we have a response to acute viral infections, such as the Epstein-Barr virus or EBV, which causes mononucleosis. And we're going to talk about that in the next slide. It can also be seen in conditions like leukemia, lymphoma, and some chronic infections. On the other side of things, if we have a lymphocytopenia, then we're going to see a decrease in our lymphocyte count, and that can result from immune deficiencies, drug destruction, viral infections, radiation, or conditions like AIDS. And a low lymphocyte count is going to weaken our immune system, and that leaves our patients vulnerable to infections once again. So like I said, we'll talk about infectious mononucleosis, which is also known as mono. And this is a self-limiting viral infection that primarily affects our B lymphocytes or B cells. And it's usually caused by the Epstein-Barr virus, and that accounts for about 85% of the cases. And our transmission will occur through the saliva, hence the name or nickname rather, the kissing disease, but the virus can also be found in respiratory, genital, and blood secretions. Our symptoms are typically going to start with a general malaise and joint pain, but the classic triad would include a fever, pharyngitis, and swollen cervical lymph nodes. So our diagnosis would then be confirmed by the monospot test, which detects the heterophilic antibodies. And to treat it, unfortunately, there is no cure. It's all about managing the symptoms. We need rest, hydration, and we can use analgesics like ibuprofen, but aspirin should be avoided in children because there's a high risk of Reye syndrome. And antibiotics like penicillin or erythromycin can be used if a secondary bacterial infection does develop. And it may be worth mentioning that, yes, we want to encourage rest, but also just in case at the younger ages too, you want to avoid any contact sports to prevent splenic rupture, and also monitor for any complications like airway obstruction or prolonged fatigue. All right, another question here for you. Which information is correct regarding infectious mononucleosis? Infectious mononucleosis in children is... And if you answered number 1, you are correct. Mono is a lymphoproliferative clinical syndrome produced by acute viral infection to B lymphocytes. And we know that its causative agents could be things like the Epstein-Barr virus, but also includes CMV, adenovirus, hepatitis, HIV, and influenza A and B. Moving on to learn a little bit more about leukemias, we've kind of mentioned them as some of the reasons why we have those changes in the number of our white blood cells. But this group of disorders is a malignant disorder of blood and bone marrow, and it's characterized by uncontrolled proliferation of abnormal leukocytes. And as these cancerous cells are going to start to multiply, they overcrowd the bone marrow. So you can see that we have lots of white blood cells over here. Now, typically these are pretty sparse amongst the red blood cells. And so when we overcrowd the bone marrow, it disrupts the production of normal blood cells, and this can lead to anemias, infections, and bleeding complications. And we are going to classify leukemias by their predominant cell of origin. That could either be myeloid or lymphoid, and their rate of progression. So I wanted to take you back to this image over here to demonstrate, again, we have that blood stem cell, and there's that myeloid stem cell that is going to give rise to some of these, like our granulocytes, our platelets, our red blood cells, whereas the lymphoid stem cell, that's focusing more on our lymphocytes. So like we said, we classify them based on that predominant cell origin, myeloid or lymphoid, and their rate of progression. So the progression could be either acute or chronic. So our acute leukemias are going to progress rapidly, just as the name acute suggests, and it's with our immature cells, while the chronic leukemias are going to develop more slowly and often with more of the mature but dysfunctional cells. We'll see patients that are suffering from this have fatigue, frequent infections, and sometimes unexplained bruising. And so we want to get some lab values and kind of get a feel for what's going on, do our best to prevent infections and manage any anemias that arise, and of course provide some emotional support. So let's start off talking about, again, some of the differences between acute and chronic leukemia. So with our acute leukemia, it's going to be more aggressive, and it's marked by the presence of those immature or sometimes even undifferentiated blast cells. And it has a rapid onset, and without treatment, unfortunately, there is a short survival time. Patients will typically have sudden fatigue, frequent infections, and easy bruising due to the rapid overcrowding in the bone marrow. Whereas with our chronic leukemia, that progresses slowly, and the abnormal cells are more mature but don't function properly, and will have a gradual impairing of the immune function over time. So the patient may begin in the early stages being asymptomatic, with diagnosis being found typically during routine blood work. So typically with leukemia, it doesn't just arise out of nowhere. There's these specific risk factors that are going to increase someone's likelihood of developing the disease. So it could be environmental exposures such as cigarette smoking, benzene, a chemical found in industrial settings. There was also just a release of certain products that were on shelves that contained benzenes. They were like facial cleansers and lotions, I think, that contained them. So they just had a massive recall because of that. And ionizing radiation, which is also a known contributor. And certain viruses can also play a role, which could include HIV, hepatitis C, and human T lymphotropic virus type 1. Which can alter our immune function and trigger abnormal blood cell production. There's also some medications that suppress bone marrow function that can increase leukemia risk over time. And a key complication of leukemia is pancytopenia, which we talked about at the beginning of this chapter lecture, where we're going to see an effect of all blood cell types, including our red blood cells, white blood cells, and platelets, that become reduced. And since leukemia is both an accumulation disorder, meaning that, well, it's really referring to that crowding out of the normal cells that we see in the bone marrow, and it's also known as a proliferation disorder with that uncontrolled malignant growth, our nursing care is going to focus on infection prevention, managing the anemia and the thrombocytopenia, and supporting patients through that treatment. Now let's go into the different types of leukemias. This one is called or acute lymphocytic leukemia. It's the most common leukemia in children, and it's characterized by an overproduction of the lymphoblasts. And so we're creating these immature white blood cells, and it makes up about 30 or more percent of our bone marrow or blood cells. And so this can lead to anemia, increased infection risk, and easy bruising or bleeding, like we mentioned. And a key genetic factor in all is our Philadelphia chromosome. And that's an abnormal translocation that occurs between chromosomes 9 and 22, which alters normal cell growth. Well, we're not really sure what the exact cause of all is. The risk factors are including prenatal X-ray exposure, postnatal high-dose radiation, chemotherapy, and certain genetic disorders, and also having a sibling with all. Some things these patients may also experience is bone pain and swollen lymph nodes. And if they're experiencing that, you want to make sure that they get prompt evaluation. And here is a peripheral blood smear. I believe that this is a peripheral blood smear, not like bone marrow, where we are seeing some of those immature lymphocytes within here. Some of them even have double nuclei. And now for our other acute type, which is AML, standing for acute myelogenous leukemia. And this is the most common leukemia in adults over 50 years old. And it occurs due to genetic alterations affecting transcription factors, leading to chromosomal translocations and a failure of our blood cells to mature properly. So risk factors for this would include, again, radiation exposure, that benzene chemical we talked about, chemotherapy, and hereditary conditions. And just like the other acute leukemia, this will progress rapidly, and patients often are going to present with symptoms like fatigue from their anemia, increased bleeding due to having low platelet counts, and fever from infections. And we do have some other signs that would include things like weight loss, muscle atrophy, a loss of appetite or anorexia, and even difficulty swallowing. And in some cases, it can even affect our central nervous system, which can cause neurological problems. So if you have a clinical case and it's characterized by an overproduction of abnormal immature white blood cells called myeloblasts or myeloid blasts, and also is having some type of neurological effects, which could include headaches, seizures, cranial nerve problems, other types of neurological symptoms, then that is a clue that it might be this type of leukemia. Now, to diagnose these acute leukemias, we start with a peripheral blood smear and bone marrow test to identify any abnormal looking cells. And once we get diagnosed, the treatment will focus on eliminating the cancerous cells while managing the complications that came up. Chemotherapy is going to be our mainstay of treatment, but patients often need supportive measures like blood transfusions for their anemia and antibiotics or antifungals or antivirals to help prevent infections or manage infections. And for some, stem cell or bone marrow transplants offer a potential cure. And complications, unfortunately, are common. Like we mentioned, anemia could be treated with blood products, while neutropenia, which we know is going to be a dangerous drop in our white blood cells, specifically neutrophils, would require maybe that granulocyte colony stimulating factor in order to boost that white blood cell production and help boost our immune function. And here's another question for you. A nurse recalls that acute lymphocytic leukemia, or ALL, and then we're going to choose which answer choice here makes sense, which is the true statement. So pause the video if you need more time, but the correct answer is number 3. ALL is an increase in our lymphoblasts to more than 30%. It's also the most common leukemia in children. It has a higher mortality rate in adults, and we know that acute myelogenous leukemia, or AML, is caused by an abnormal proliferation of myeloid precursor cells. Now let's discuss the chronic leukemias that, remember, are going to develop slowly and often go unnoticed until they're doing some type of routine blood work and we pick them up based on the abnormalities. So we'll start with our chronic myelogenous leukemia, or CML. This is the most commonly diagnosed within adults in their 50s or 60s, and it's going to originate from hematopoietic stem cells and is linked to that Philadelphia chromosome as well, where the BCR-ABL1 gene drives uncontrolled cell growth. And while treatments can manage the disease, unfortunately, there is no cure. The other type is known as chronic lymphocytic leukemia, or CLL, and that's the most common leukemia in adults, affecting monoclonal B lymphocytes, and it progresses slowly with an 85% survival rate. Its cells are going to be expressed as high levels of pro-apoptotic proteins that prevent normal cell death, and so it allows the cancer cells to start to accumulate. Now let's talk about the clinical manifestations. Like we said, we won't really see symptoms at the beginning because these leukemias are progressing slowly, right? So in the CCL type, patients are going to be asymptomatic at diagnosis, but as the disease advances, we can start to see lymphadenopathy, and that means we've got swollen lymph nodes. This tends to be the most common finding. We'll also have suppressed humoral immunity, which, if you remember, humoral immunity is going to involve our B cells, them differentiating into plasma cells and secreting antibodies. So with that being suppressed, it makes the patients more vulnerable to infections, especially from encapsulated bacteria. And then as far as our clinical manifestations for CML, it's going to follow 3 phases. The chronic phase is going to last 2 to 5 years with mild to no symptoms. And in the accelerated phase, which lasts about 6 to 18 months, we'll see symptoms like splenomegaly, which is an enlarged spleen, infections, fever, and weight loss, which becomes more apparent as time goes on. And then the final blast phase is known as the blast crisis. And that's an aggressive stage in which we're going to see severe complications and a survival rate of only 3 to 6 months without any interventions. In order to diagnose leukemia, we of course need blood tests and bone marrow analysis so we can look at the abnormal white blood cell activity. Once they're diagnosed, treatment is going to vary depending on which type of leukemia we have and the progression of the disease. So if we have the CCL type, then treatment will focus on managing infections, hemorrhages, and immune complications. Chlorambucil, sometimes combined with corticosteroids, is commonly used along with chemotherapy. Now, if we have the CML type, that has no definitive cure, but we can combine it with chemotherapy, biologic response modifiers, and allogenic stem cell transplantation to help manage the disease. And there's targeted therapies that improve outcomes in most instances, but this type of leukemia is going to require lifelong monitoring. All right, we've covered all the leukemias. Now let's shift gears into lymphadenopathy, which refers to enlarged lymph nodes that become palpable and tender. You can see that over here in the inguinal region and even in the axillary region and cervical region, where we have those lymph nodes very close to the surface of our skin. And you could see it down in this region over here too, a little bit more of a lateral view of that cervical area. And so it could be classified as either local, like we see in the cervical region, or it could be generalized. So local lymphadenopathy usually occurs due to an inflammatory lesion near the affected node, such as some type of infection or surgery. And in contrast, generalized lymphadenopathy is going to suggest a systemic type of condition, whether it is malignant or non-malignant. Common causes of this could be neoplastic diseases like leukemia or lymphoma, immune disorders such as lupus, endocrine issues, lipid storage diseases, or even unknown factors. So you may, when you see swollen lymph nodes like this, want to assess the size, the tenderness, and the duration the lymph node has been enlarged and make notes of that. So we want to also seek medical attention if this is quite prominent and has persisted. And now for our next topic, which is malignant lymphomas, which are a diverse group of cancers that are going to arise from uncontrolled proliferation of malignant lymphocytes in our lymphoid system. So these cancers develop in either primary lymphoid tissues or secondary lymphoid tissues. If you remember from AMP, our primary lymphoid tissues would include our thymus and the bone marrow, right? Where our T cells and B cells go to mature. Whereas our secondary lymphoid tissues, like our lymph nodes, which you can see pictured here and here, our spleen, our tonsils, which aren't really pictured, but they would be right around this area, and our intestinal lymphoid tissue would be included in that. So if you have a patient that is having symptoms of maybe a painless swollen lymph node, fever, night sweats, unexplained weight loss, and fatigue, you might get your ears perked up thinking that it might be a lymphoma. So let's learn about some of the different types of lymphomas. We classify malignant lymphomas into 2 major categories, which is Hodgkin lymphoma and non-Hodgkin lymphoma. Hodgkin lymphoma is often linked with that Epstein-Barr virus, just like we saw with infectious mononucleosis, and is characterized in this case by the presence of something known as Reed-Sternberg cells. We're going to take a look at that in the next slide, I believe. And typically it's going to follow a pretty predictable spread from one lymph node to another and has high survival rates if it's treated early. With our non-Hodgkin lymphoma, it's going to be more of a diverse group of lymphoid cancers that can arise from genetic mutations or viral infections. And these can be indolent, meaning that they're slow growing, or aggressive, meaning that they're going to rapidly progress. And it affects both B and T cells. And so here's a picture of that Reed-Sternberg cells that we talked about that we are going to find within our lymph nodes. These cells are derived from malignant B cells and should undergo apoptosis or programmed cell death, but instead are going to survive and release cytokines. So you can see a cartoon drawing of what that type of cell looks like down here too. And those cytokines contribute to the disease progression. So we have two types of Hodgkin lymphoma. There's our classic Hodgkin lymphoma and our nodular lymphocyte predominant Hodgkin lymphoma. And our classic is the most common type, while the nodular type is a little bit rarer and progresses more slowly. We don't for sure know the cause of this type of lymphoma, but we know there's some type of viral involvement, and we discussed in the previous slide how it's typically due to the Epstein-Barr virus, but it could also be familial clustering, so there might be a genetic factor that plays a role that may cause these Reed-Sternberg cells to pop up. And just for a fun fact, since I said pop up, these cells are also referred to as popcorn cells because of the way they appear under the microscope. So some of the clinical manifestations that we're going to find is what you see pictured here at the arrow, a painless swollen lymph node, and it's typically found in the neck, or it could be in the chest or underarm, so somewhere more in the upper part of the body. And as the disease progresses, lymphadenopathy that we discussed a couple slides ago can cause pressure or obstruction, which can lead to symptoms like a mediastinal mass, fever, night sweats, weight loss, pruritus, and fatigue. And for diagnosis, the biopsy is going to be the most definitive test, though chest x-rays and lymph angiographies can also help assess the disease progression. And like we said, if we have early treatment, there is a high cure rate, about 75%, and that treatment typically will include radiation and chemotherapy. And in more advanced cases, we can use high-dose chemotherapy followed by bone marrow or stem cell transplantation. And there are some newer therapies like monoclonal antibodies and non-myeloablative allogenic stem cell transplantation that have been really promising. All right, now for non-Hodgkin lymphoma, which can be classified as B cell neoplasms and also includes our T cells and natural killer cell neoplasm. So according to our WHO real classification, this cancer is often driven by chromosomal translocations leading to the clonal expansion of our B cells, which is around 85 to 90% of our cells, and T cells or NK cells. So unlike Hodgkin lymphoma, the Reed-Sternberg cells here are absent, and instead we have mutations in proto-oncogenes and tumor suppressor genes that disrupts our normal cell regulation and allows for uncontrolled proliferation of these malignant cells. And you could see some of our causes and risk factors over here to the left, like being over the age of 60, having viral infections, immune system abnormalities, exposures to chemicals, or a family history of lymphoma. And let's talk about some of the clinical manifestations. We see it present with localized or generalized painless lymphadenopathy with nodal enlargement that progresses over months or even years. And some patients can develop retroperitoneal and abdominal masses that can lead to an abdominal fullness, back pain, ascites, or leg swelling. And similar to what we saw in Hodgkin's lymphoma, a biopsy is going to be the gold standard for diagnosis, and it helps determine the type, stage, and grade of the lymphoma. Survival rates are going to vary with this type, with treatment tailored based on factors like B cell versus T cell origin, the tumor grade, symptoms, and the patient comorbidities. And our treatment options are going to include chemotherapy, radiation therapy, and monoclonal antibodies like rituximab. And we can also use radioimmunotherapy, which combines radiation with targeted monoclonal antibody therapy that has shown some promising results. Another type of B-cell non-Hodgkin lymphoma is Burkitt lymphoma, which is highly aggressive and is going to present differently depending on its location. In Africa, it's known for causing rapidly growing tumors of the jaw and the facial bones, which you can see pictured over here, mainly on that mandible. While in the United States, we often see that it leads more to abdominal swelling. And this lymphoma is strongly linked to the Epstein-Barr virus, with over 90% of cases testing positive. And our diagnosis is going to rely on biopsy or bone marrow analysis to confirm the presence of the malignant B cells. Lastly, treatment is going to include chemotherapy as a primary approach, often combined with monoclonal antibody therapy, such as rituximab, to target cancerous cells more effectively. And then we have our lymphoblastic lymphoma, which is rare, but it is an aggressive type of non-Hodgkin lymphoma, and it accounts for about 2 to 4% of cases overall, but 20% of the lymphomas in children and adolescents, with a higher incident in males. And more than 85% of cases are going to originate from T cells, with immature T cell clones becoming malignant in the thymus. The first sign is often painless lymphadenopathy in the neck, which you can see pictured over here, and that may progress rapidly, and diagnosis is going to require a biopsy and imaging, and treatment will involve intensive multi-drug chemotherapy so that we can target those rapidly dividing cells. And here is a question for you. A nurse observes the Reed-Sternberg cells on a laboratory result. The nurse is caring for an individual with, and I hope you picked this one out very quickly because it's the only one that has these types of cells. The answer is number 1, Hodgkin lymphoma, where we see those popcorn cells or Reed-Sternberg cells. They're large and often have that binuclear or mononuclear look and represent malignant transformed lymphocytes and are basically diagnostic for Hodgkin lymphoma. Now, our plasma cells were the end-stage cells of our humoral immune response. I kind of described this before, where in our humoral immune system, we have our B cells that are going to differentiate into plasma cells, which are the ones that are responsible for producing antibodies. However, when these cells become malignant, they can give rise to serious conditions. And 2 key examples of plasma cell malignancies would include multiple myeloma, which is a cancer of antibody producing cells that are affecting the bones and our kidneys. And we also have Waldenstrom macroglobulinemia, Wow, cannot say that 5 times fast. But that is a rare disorder where abnormal plasma cells are overproduced and a thick protein known as IgM, and that leads to blood viscosity issues. And so as a nurse, you're going to have patients with these malignancies that are going to require you to monitor for infections, bone pain management, and assistance with their fatigue and anemia. So we do want to recognize any complications that may arise with this, such as hypercalcemia and renal dysfunction. But let's talk about the 2 different types and more specifics about each. So we'll start with multiple myeloma, which is going to be a malignant disorder where our plasma cells are proliferating uncontrollably in the bone marrow. And the primary genetic abnormality is going to involve a translocation of the immunoglobulin heavy chain on chromosome 14. And this then leads to a production of excessive amounts of a single class of the immunoglobulin. And so a key marker of multiple myeloma is the presence of the M protein, which is an abnormal antibody molecule. And we may also find some Bence-Jones proteins, which are unattached light chains that can pass through the kidneys and cause renal damage. So like we said, in these patients, we want to monitor for kidney function, manage any bone pain, and prevent infections. These patients may be experiencing anemia, fractures, and hypercalcemia, which is going to require hydration, mobility support, and pain control. Let's talk more about their clinical manifestations. So we mentioned hypercalcemia. That is going to occur as the bone is broken down, and that can lead to fatigue, confusion, and kidney disruption. Renal failure is going to be a common thing due to the Bence-Jones proteins because they're damaging the kidneys. And then our patients also develop anemia, causing weakness and pallor, and lytic bone lesions, which are going to appear as punched out holes on imaging, and that can lead to skeletal pain and fractures. They can also develop hyperviscosity syndrome, which may impair their circulation and the loss of the humoral immune response, which makes the patients really susceptible to recurring infections. Now, for diagnosis, we're going to rely on radiographic imaging, laboratory tests, and a bone marrow biopsy to confirm the malignant plasma cell infiltration. For treatment, unfortunately, the prognosis is poor, but the treatment advances are improving outcomes. Therapy often will involve a combination of chemotherapy and drug therapy, targeted drugs, that is, and a biologic therapy to slow the progression of the disease. High-dose chemotherapy followed by blood-forming stem cell transplantation offers some patients prolonged survival. And then there's newer approaches like tandem transplants and thalidomide-based regimens, which are showing promise. And to manage complications, bisphosphonates help reduce skeletal damage, while hydration and diuretics can help maintain kidney function. And since infections are a big concern, antibiotics can also be really helpful. And in severe cases, plasmapheresis helps to remove excess abnormal proteins from the blood. And then when we have alterations to splenic function, we know that the spleen is going to be important for filtering our blood and supporting our immune system too, right? But when its function becomes abnormal, we're going to start to see some complications arise. So if we have splenomegaly, that means we have an enlarged spleen, and that can indicate underlying disease and may become pathologic. And one concern is hypersplenism, which is where we have an overactive spleen, and then it tends to destroy blood cells too quickly, which can lead to anemia and thrombocytopenia. When we have congestive splenomegaly, that is common in hepatic cirrhosis. It results from increased blood pressure in the portal system. If you remember that hepatic portal vein, we might need to revisit that. Let me know if you want to go over that anatomy again. And then we have infiltrative splenomegaly that occurs when macrophages accumulate indigestible materials, and that's often due to some type of metabolic storage diseases. And a key manifestation of splenic dysfunction is when we have anemia from excessive red blood cell destruction, and in severe cases, splenectomy or the surgical removal of the spleen is going to be required to manage those symptoms. So we're going to end this lecture here, and then I'll have a separate lecture on alterations of our platelets.